Hello, everyone. In today's installment of Intern Crash Course, I'm talking about COVID-19. Consistent with the other videos in this series, this will focus on the presentation, diagnosis, and management of COVID, along with a discussion about PPE. This video will not cover epidemiology, policy, or politics. Only the essentials of what frontline healthcare professionals need to know to take care of patients with this awful disease. This is likely obvious, but keep in mind that there is an unprecedented volume of research being performed and published about COVID. Therefore, while I have done my best to make the information presented in this video as accurate as possible, some of it will become outdated over the coming weeks and months. I'll start by clarifying two relevant terms. SARS-CoV-2 is the name of the virus. This is to distinguish it from SARS-CoV-1, the similar coronavirus that was responsible for the SARS epidemic of 2003. COVID-19 is the disease caused by the SARS-CoV-2 virus. COVID-19 stands for Coronavirus Disease 2019. Now let's discuss the clinical presentation of COVID-19. Fever, fatigue, and dry cough are the most commonly reported symptoms. While almost all symptomatic patients will develop a fever at some point during their illness, a significant number do not have fever at the time of initial presentation. Other well-described symptoms include anorexia, malaise, dyspnea, sore throat, headache, abnormalities of taste and smell, and diarrhea, the last of which is the predominant presenting symptom in a small minority of patients. Among all patients who develop COVID-19, approximately 80% have so-called mild disease. Mild is sort of a misnomer because it only means that these individuals do not require hospitalization. Some may still feel the sickest they have ever been. This is not a trivial illness for most. 15% of patients will be classified as severe on account of requiring hospitalization, usually for dyspnea and hypoxemia. And 5% of patients will be classified as critical, meaning ICU admission, usually for ARDS and or multi-organ failure. Here's the time course of symptoms for a typical patient ill enough to require hospitalization. It starts with an asymptomatic incubation period ranging from about 2 to 14 days with a median length of 4 to 5. At least some patients will be contagious during the tail end of this asymptomatic period. The initial symptoms to develop are most commonly fever and cough, which can last the duration of the illness, though in some patients, fevers cease before full recovery. Then, in the 20% of patients requiring hospitalization, dyspnea develops after about a week, which then coincides with the typical timing of their admission. Anecdotally, the onset of dyspnea can be relatively abrupt. About a quarter of hospitalized patients will have ARDS plus or minus multi-organ failure follow the onset of dyspnea by a few days. Either recovery or death usually occurs between 2 and 3 weeks after initial symptom onset. For patients with mild disease not requiring hospitalization, recovery typically is seen more quickly. An uncertain percentage of patients infected with the SARS-CoV-2 virus remain asymptomatic but are nevertheless contagious. While many COVID-19 patients who present with dyspnea have hypoxemia and or pulmonary crackles, there are no physical exam findings that are specific enough to be diagnostically helpful. While there are no pathognomonic lab findings in COVID-19, it is commonly associated with a distinctive combination of abnormalities, including lymphopenia, that is a decreased lymphocyte count, an elevated LDH, and an elevated CRP. When it comes to radiographic findings, while some findings are now being considered typical of COVID, they are nevertheless nonspecific. But what are some common findings? On chest X-ray, approximately 1/3 of them are normal at the time of initial presentation. However, the majority of patients show patchy infiltrates and or consolidation, most commonly in a bilateral, peripheral, and basilar distribution. These findings and this pattern become most apparent at least 1 week after the onset of symptoms. Pleural effusions are uncommon. On chest CT, most patients have bilateral subpleural ground glass opacities, and as with plain chest films, consolidations can be seen, particularly late in the illness. There are some potential complications of COVID-19. As already mentioned, one is hypoxemic respiratory failure, secondary to ARDS. This appears to be the most common mechanism of death, and which can be accompanied in a minority of patients by bacterial superinfection requiring antibiotics. Some critically ill patients also develop a cytokine storm syndrome, which is clinically similar to secondary hemophagocytic lymphohistiocytosis. Manifestations of this include cytopenias and organ failure, driven by excessive cytokines and subsequent hyperinflammation. Another complication in critically ill patients is diffuse microvascular thrombosis, which is predominantly suggested by an extremely elevated D-dimer, but also may be associated with an elevated INR and PT, low platelets, and low fibrinogen. These labs can look similar to acute DIC, except that in classic acute DIC, bleeding is the predominant manifestation rather than the pathologic thrombosis seen with COVID. Last is cardiomyopathy. It is not yet known whether cases of this are caused by viral myocarditis, stress cardiomyopathy, also known as Takotsubo cardiomyopathy, ischemic injury from microvascular damage, or the aforementioned cytokine storm. Let's move on to diagnosis. A diagnosis of COVID is based upon symptoms, the current disease prevalence in the community, and a reverse transcription PCR test for the virus, usually performed on nasopharyngeal swabs. In settings where the RT-PCR test is not available, a patient with consistent symptoms, coming from a community with a relatively high prevalence of the disease, and in whom other diagnoses have been ruled out, can be considered to have presumed COVID and should be treated accordingly. The major limitations of the RT-PCR test include the fact that there is currently no gold standard for the diagnosis, so we don't know the true sensitivity and specificity of the test. Whatever the sensitivity of the test happens to be, it will be dependent upon the phase and severity of illness, as well as collection technique. Proper collection requires inserting the swab deeper into the nasopharynx than most people realize, and it is uncomfortable if done correctly. Also, different labs have developed slightly different tests, and it's unknown how the sensitivities compare between them. If there is high suspicion that a patient has COVID-19, but the initial RT-PCR test is negative, you should consider keeping the patient isolated either in the hospital or at home, and then having them retested in several days if the uncertainty still remains. As of this recording, there is no commonly available serologic test for anti-SARS-CoV-2 antibodies that might demonstrate past infection and immunity from future infection. However, antibody tests are expected to be available very soon. Treatment of COVID-19 is predominantly supportive and is focused mostly on improving oxygenation, as that is the primary problem in the overwhelming majority of severe and critical cases. So, how do we do that? For patients with severe but not yet critical illness, that is, who are pre-intubation, start with regular old low-flow nasal cannula. If that's insufficient, upgrade to high flow, keeping in mind that high flow oxygen is an aerosol generating intervention requiring a negative pressure room and additional PPE for providers if those are available. An intervention that has gotten very little attention in pulmonary diseases prior to COVID, but which has been found, at least anecdotally, to be very helpful, is awake prone positioning. Some patients will find this uncomfortable, so adherence can be a major challenge. And consider the selective use of non-invasive positive pressure ventilation. Decisions about whether to employ CPAP or BiPAP for a given patient need to balance four things: the probable relatively low benefit of NIPPV in COVID-19, the preservation of invasive mechanical ventilators, the relatively low rates of successful extubation in these patients, and the increased risk to staff from NIPPV on account of aerosolization of secretions. The debate about NIPPV used in COVID is ongoing and unlikely to be settled anytime soon. Speaking of areas of debate, let's talk about intubation. Patients with COVID can experience extremely rapid respiratory deterioration after a period of apparent stability. This has led many critical care experts to advocate for so-called early intubation, for example, intubating patients at thresholds of hypoxemia that are not as severe as usually employed. However, others have pushed back on that practice due to the same arguments favoring use of non-invasive ventilation, that early intubation may contribute to ventilator shortages and could increase mortality by unnecessarily subjecting patients to all the risks associated with mechanical ventilation, such as barotrauma and ventilator-associated bacterial pneumonia. If the decision is made to intubate, extra time needs to be allotted for the airway team to gather, prepare, and don personal protective equipment, and the intubation itself should be performed by the most experienced person present. For patients that do end up intubated, low tidal volume ventilation, the conventional approach to ARDS, is generally recommended. There are a few other approaches to modes and settings that have been tried and which may be successful. If whatever mode and settings is insufficient, prone positioning should be tried. As a last resort for refractory hypoxemia, veno-venous ECMO can be considered if it's available. However, I've heard critical care doctors raise a compelling utilitarian argument that COVID patients with refractory hypoxemia have such poor prognoses and ECMO is so resource intensive that in the middle of a pandemic, its use is not justifiable. I will leave further discussion on that to the bioethicists. As everyone is aware, there are a number of unproven COVID-19 treatments that are currently undergoing clinical trials. This won't be an exhaustive list, but I'll go through some of the ones which are currently most commonly discussed. First up is remdesivir, which is a novel nucleotide analog that interferes with viral RNA-dependent RNA polymerase, which is an enzyme necessary for RNA viruses like SARS-CoV-2 to replicate its genome. Remdesivir was originally developed for the treatment of Ebola, although a 2019 RCT found it less effective than several other alternatives for this indication. Currently, it's only available in the United States as part of a clinical trial or under compassionate use. The medications that have gotten the most press to date are hydroxychloroquine and the structurally similar but modestly more toxic chloroquine. There are multiple postulated but unproven mechanisms for how these drugs might help fight COVID-19. Hydroxychloroquine is currently used predominantly to treat lupus and rheumatoid arthritis, while chloroquine is used predominantly for malaria prophylaxis. These drugs can prolong the QT interval, so ECG monitoring is recommended, particularly in patients already on other QT prolonging drugs. Despite assertions to the contrary by laypersons and politicians, there is currently no significant evidence of clinical benefit in COVID from either of these medications. Lopinavir-ritonavir, marketed under the brand name of Kaletra, is a fixed-dose combination of two protease inhibitors that are currently used for patients with HIV. An initial unblinded RCT of about 200 patients found no benefit in COVID, and interest in this option has decreased significantly over recent weeks. Tocilizumab is a recombinant monoclonal antibody that binds to and blocks the functioning of the IL-6 receptor, IL-6 being a cytokine implicated in critical COVID-19 infections, so if effective, patients who develop the cytokine storm syndrome would seem to be the most likely to benefit. And the last experimental treatment I'll mention is convalescent plasma, in which donated plasma from COVID-19 survivors provides immunity by passing on anti-SARS-CoV-2 antibodies to the recipient. The idea of convalescent plasma has been around for over 100 years, well before scientists had any understanding of the immune system, though it's played minimal role in the treatment of infectious diseases since the advent of antibiotics and vaccinations. How do we determine prognosis in COVID-19? The true mortality rate is uncertain, but overall direct mortality rate is estimated at around 1 to 2%. Among hospitalized COVID-19 patients, direct mortality is about 5 to 10% and appears to be around 50%, give or take, among patients who become intubated during their course. There have been many identified risk factors for COVID-related death. Demographic risk factors include advanced age, particularly above about 60 to 70 years, and male sex. Comorbid conditions that are risk factors for death seem to include all the usual suspects: cardiovascular disease, chronic lung disease, diabetes, hypertension, cancer, chronic kidney disease, obesity, and any form of immunocompromise. Among patients who are admitted to hospitals with COVID, between survivors and non-survivors, there is no significant difference in symptoms prior to initial presentation, but lab tests which appear to be markers of increased mortality include lymphopenia, an elevated D-dimer with the degree of elevation related to the risk, and elevations of troponin, LDH, AST and ALT, creatinine, ferritin, and C-reactive protein. An elevated SOFA score is also predictive of mortality. So now let's discuss PPE, or the personal protective equipment necessary to prevent you from catching COVID from your patients. PPE is probably the most controversial topic in this video. PPE guidelines and recommendations differ across countries, across states, healthcare systems, and individual hospitals. And with new data on PPE effectiveness, and with local changes in PPE availability, you should expect guidelines, recs, and protocols to change. I'm going to summarize recommended PPE for the evaluation and treatment of patients with COVID, including suspected cases, commonly referred to as persons under investigation. These recommendations are based on my personal interpretation of the most recent guidelines across healthcare systems as of April 2020, influenced by opinions I have heard in person and read online from healthcare professionals who I trust. This may not be 100% consistent with WHO and CDC guidelines at the time you're watching this video, and they're subject to change with new information. For the routine care of hospitalized but non-critical patients, wear gloves. A single pair is likely fine, though extra long ones that extend onto the forearm, like sterile gloves do, are probably best. I much prefer a disposable tear-away gown rather than one that must be untied. For protection of the nose and mouth, either a conventional surgical mask, an N95 respirator mask, or a powered air purifying respirator. At my hospital, where numbers have fortunately been on the lower side, we've been using N95 masks for all COVID patients, a practice with which I am much more comfortable. For eye and face protection, I prefer a face shield, though some hospitals are using only goggles. Now, what about aerosol generating procedures? An incomplete list of these include intubation and extubation, non-invasive ventilation, high-flow O2, nebulizer treatments, bronchoscopy, upper endoscopy, and CPR. Obviously, wear gloves and a gown. Surgical masks are definitely not okay for these procedures, and protecting the full face is no longer optional, so a face shield is a must, if not using PAPR, keeping in mind that a face shield will still leave some of the neck exposed. It does seem like almost everyone agrees that disposable shoe covers are not only unnecessary, but may even be an actively bad idea, since it seems very possible to contaminate oneself when removing them. While there remains a ton of concern throughout the United States regarding the availability of appropriate PPE, its proper usage and removal is at least as important as the specific equipment available at your institution. I strongly recommend you review the specific PPE instructions for your institution and watching separate videos online that demonstrate PPE usage and removal. If your hospital has enough to spare to let you practice while being observed, that is awesome, and you definitely should make use of that opportunity. Let's discuss some common PPE mistakes that aren't dependent on the specific gear your facility is using. Common mistakes upon donning the PPE include not pulling the gloves over the ends of the gown sleeves, thus leaving your wrists exposed, and leaving your back exposed by the gown and not fully wrapping around your body. This is why it's a good idea to have a PPE buddy present to double check that you've protected yourself appropriately before entering the room. Common mistakes upon doffing the PPE, meaning when taking it off, include touching the outside of the gown or gloves with bare hands, or the front of the mask with bare hands, removing the PPE too quickly, particularly the gown, which risks flinging viral particles into the air, and taking off the mask or the respirator in the room. In general, for most combination of PPE and room layouts, the mask or respirator should be the only PPE that's removed outside of the room. One exception to this is that if you've double gloved, I can imagine removing the outer layer in the room, and the inner layer outside of the room in order to avoid touching a door handle with your bare hand, though this does run the risk of upsetting other staff members who observe you having gloved hands in the hallway, not realizing that you were double gloving. There are a few final points to make about COVID-19. Anecdotally, some patients appear to develop hypoxemia that is out of proportion to both their symptoms and the complications of hypoxia, what's referred to as silent hypoxemia. The relative lack of symptoms may be related to also anecdotally reported preservation of lung compliance in COVID-19 pneumonia, such that the work of breathing is not increased to the same degree seen in other forms of diffuse lung injury. A non-negligible number of COVID patients are co-infected with another respiratory virus. The most important consequence of this is that one should not rule out COVID solely on the basis of a rapid routine respiratory PCR panel that is positive for something else, while a COVID-specific RT-PCR is still pending. For COVID patients, whenever possible, inhaled medications should be delivered in the hospital via metered-dose inhaler rather than nebulizer to limit aerosolization of viral particles. The treatment of acute bronchospasm is one exception in which nebulized meds may still be necessary. And last, because the SARS-CoV-2 virus enters cells via angiotensin-converting enzyme 2, there's been a lot of interest in the role that ACE inhibitors and ARBs might play in either the susceptibility to infection or to its management. However, there is currently insufficient evidence to recommend either the initiation or the discontinuation of ACEs and ARBs in patients with COVID. That's it for this video on the presentation, diagnosis, and management of COVID-19. As discussed at the beginning, knowledge about this disease is evolving at an incredibly fast rate, so please keep that in mind and stay safe out there.